Okay. Hello. I would like to thank everyone for attending this afternoon's webinar. I would like to first give our attention to Mr. Wallace Johnson here. He is going to first introduce us to the Lacan Grassroots Advocacy Network. He's going to give us some information on that prior to Miss Jenny giving us some information. I also want to inform you um, of what webinar we are introducing tonight, just to make sure that you are in the correct place. Our webinar is Feeding Challenges in Infant Toddlers and Beyond. Um, it will be, our information will be presented by Ms. Jenny Dees. So with all of that said, I will go ahead and I will give the floor to Wallace Johnson. Thank you, Wallace.
Thank you, China. And I'm going to talk briefly about Lacan because I know we want to get to the topic at hand for the webinar. So I'm going to briefly talk about it. In the chat, you should see a link for the Louisiana Council's Advocacy Network. Uh, we know it as Lacan, and that's what Lacan stands for, is the Louisiana Council's Advocacy Network. It's a statewide grassroots advocacy network. Um, Anybody can join this. But what it does, its purpose is to link lawmakers and individuals with disabilities and family members to make positive change in systems serving people with disabilities. It also advocates for policies and systems that support inclusion everywhere people learn, work, live, and play. It also advocates for systems that support children and adults with disabilities to live in their own communities and be fully included and participating members of their local schools and communities. Lacan leaders provide connection with a regional team of advocates, provide information on proposed policy changes and how these changes may affect you and others, and also provide training in skills to effectively advocate for system change and to support you to link you with policymakers. And so the link for Louisiana Council's Advocacy Network, Lacan, is www.lacanadvocates.org. And you should see that in your chat. So, with me finishing that, I'll turn it back to China so we can get started.
Thank you, Wallace. I appreciate that. Okay. Okay, so today we are pleased to welcome Miss Jenny Dees, a very special guest from Lake Charles. Jenny is an occupational therapy that work with Therapy Works. Today, she will be sharing with us her expert opinion on feeding issues. Please put all your questions in the chat box and we will answer those throughout the webinar. Wallace is assisting me and will be sending out this PowerPoint, the survey link, and certificates at the end of this webinar. With all of that said, I ask you to give your full attention to Ms. Jenny D and help me welcome her to our platform. Thank you, Miss Jenny. I give you the floor.
Okay, thank you, China. Can everyone hear me okay? If you can't, type something. So my name is Jenny Dees. I'm an occupational therapist and oh, that's cool. Sorry, y'all. I get distracted easy. I'm not really a presenter, but China's a friend and she asked me to do this. So let's get started. Mr. Wallace is helping me run the PowerPoint. So he's going to do the slides for me. So we've all heard these old feeding adages, you know, your child will eat when they're offered and what they're offered when they're hungry enough. A child won't starve themselves. Uh, my parents, if you don't eat what you're served, you'll go to bed hungry. All these things. What I have found in my years of practice is that this is not always correct. there are children that will starve themselves if they are not given food that they find as safe foods due to a variety of reasons. So this isn't a catch-all approach. Okay, we can do the next slide. Yeah, you're good. So a little bit about me. I practice in Lake Charles. I graduated from UTMB Galveston in 2015, and I've worked in a lot of settings. I've worked with children, adult, outpatient, inpatient, early steps, hippotherapy, which is horseback riding, therapy, LTACs, lots of places. I specialize in feeding. I do a lot of work with birth through childhood with feeding. I think my youngest patient was like 3 days old. I'm trained in TOPS, which is tethered oral tissue. I also do a lot of sensory-based feedings, and I'm working towards becoming a lactation consultant. In addition to all that, I'm a mom of 4 kids, my husband, who's really another kid, and we have 11 pets. So what got me started in this feeding route? So these are pictures of 2 of my kids. So my oldest child, when he was about 1.5, I realized he had significant sensory feeding issues. I was in occupational therapy school at the time, and I basically got no help from anyone. It was a, hey, wait and see, he'll eat when he's hungry thing. Well, then I realized his tonsils were so big he couldn't swallow. And so I kind of, through trial and error, taught myself texture progression and reinforcement for feeding and things like that. And then my 3rd child came, and that's a whole other story. We've been through multiple tongue tie revisions, swallow studies, speech, OT, PT, whole lots of stuff. So, next slide. Okay, so feeding therapy is a specialized form of therapy that helps children or adults after injuries like a stroke or something achieve normal eating patterns and behavioral patterns. It can involve a wide variety of people: OT, PT, speech, ABA, GI, nutrition, psychiatry, dentistry, counseling. And most of the time, it requires these professionals to be trained more than what's presented to them in their general schooling. You can do the next slide. Okay, so who can benefit? Pretty much anyone who's struggling in feeding, whether they're an infant, an older adult, they're transitioning from G-tubes, they have a cleft palate, they're picky eaters and they just want to change how they eat, they're a parent who isn't happy with how their children eats, can be anyone. Okay, so first we're going to look at some common feeding problems I see in the young infants. Those I classify as infants who aren't ready for solids yet. So there's a couple different things that I see a lot. Tongue and lip ties are a frequent one. Difficulty coordinating suck, swallow, breathe pattern, difficulties with flow rates, and various medical conditions. Okay, so tongue and lip ties. So these are pictures of my patients pre-frenectomy, which is a procedure to sever that tissue that's keeping the lip and tongue stuck down, and post-frenectomy. And you can see, if you look close, I know it's kind of small, there's a lot more range in motion. So tongue and lip ties are a real thing. I know some people don't really believe in it, but there's references all the way back to the Bible. It causes difficulties with both breast and bottle feeding. So in breastfeeding, a lot of times the infants that I get, the infant mother dyads, the moms will be in a lot of pain. Their milk supply is tanking and they don't know why, because they're pumping and pumping and feeding and nothing's happening. They try and latch the baby on and the baby's constantly falling off and everyone's frustrated and everyone's crying. A lot of times these babies that are exclusively breastfed and struggling with tongue and lip ties will have poor weight gain, or whenever there's milk leaking everywhere. Also, they're frequently very gassy, very spitty up babies, or they'll be feeding for like 30 minutes to an hour. An average feeding session for a young infant should be about 15 to 20 minutes. Otherwise, we start spending more calories than we're intaking. So tongue ties can cause a lot of these issues, and a simple procedure done by a dentist or ENT who's skilled in this is what's needed to fix these truly anatomical issues. Just so you know, as an occupational therapist, I'm not allowed to diagnose a tongue or lip tie. I simply write up a report to a dentist or ENT stating, this is the tissue I see, this is how it's restricted, and this is how it's affecting their function. And then they're the ones who diagnose and decide. With bottle feeding, because a lot of these dyads that I see, they tried breastfeeding and breastfeeding failed. Either it was too painful, baby wouldn't latch, or mom's milk supply dried up. And so they just thought it was because of mom. It really wasn't. It was the baby. So then they switched to bottles. And then we have the bottles leaking everywhere. We're trying 6, 7, 8, 9, 10 different types of bottles. We're still making a huge mess. We need to burp every half ounce. A nightmare. If this is something that you suspect may be going on, it's honestly something that needs to be evaluated by a trained professional, because there is certain ways to check for these ties that not everyone knows. You can go to the next slide. Okay, so another thing I see is difficulty with suck, swallow, breathe coordination. These babies will cough a lot. They'll be very wet sounding or gurgly after a bottle. You'll hear like gasping and gulping or milk spilling out of the mouth. In these cases, there is an increased risk for the milk going down the wrong way, which can lead to frequent pneumonias and things like that. Some good interventions for this, if you notice your baby is having trouble with these, things that you can do at home even before seeing a specialist, is one technique I like is called pacing. So basically, you're feeding, I don't have a real baby, sorry. So you're feeding your baby, you listen for like 2, 3 sucks, and then you tilt the bottle so that they can breathe. So for babies like this. So 2, 3 sucks, tilt the bottle, baby can catch their breath. And same thing. You can also, how I just had, instead of the baby laying flat, you can put the baby more upright and hold the bottle horizontal. That prevents gravity from helping that milk come out. It makes the baby do all the work. You have to be careful with that, because if you notice, hey, now it's taking baby 30, 40 minutes to eat, then we've got other stuff going on. And so returning them back to this position and just this can be helpful. Another thing you can try is a slower flow nipple. Nipples come in different sizes, and there's no standardization between brands. So a level 1 Avent bottle may be a level 3 Dr. Brown's bottle. Kind of trial and error. Next slide. Yeah, so flow rate, that's what I just talked about it. They're not standard. So suppose you're a family and you have this bottle and you really can't afford to go buy 27 different bottles and nipples to try out which one's best, because bottles and nipples are very, very expensive. Some things you can do to help if you notice it's going too fast are the pacing. What we just went over, where we either have the bottle tilting or we sit the baby upright. That's great for nipples that are slower, that are too slow for the baby. Or sorry, too fast for the baby. When it's too slow for the baby, use gravity to your advantage. So get the baby flatter and the bottle more upright. It'll make it flow a little bit faster. Ideally, the intervention would be to change the nipple size or bottle, but those are things you can do if that's not an option. So, okay, some other issues, and these all need to be treated by trained professionals, but just so we know that they're there, medical conditions are a big factor in feeding difficulties. Heart defects cause poor pulmonary function, which cause increased fatigue, which compounds by poor feeding. Cleft lip palate requires numerous specialists and revisions. Allergies and sensitivities. If you notice your baby is super fussy, this is especially true for a breastfeeding diet. If you notice your baby's fussy, start keeping a log of what you ate and when you ate it, and see if you can find a correlation between that. It's an easy thing to do at home, and then you can present your information that you gather to your pediatrician so they can help you make the best choice. If you're a formula-fed baby and we're having excessive spitting up and fussy and cranky, talk with your pediatrician about switching. There's lots of different formulas, and they're the ones that can guide you best. So reflux versus arophagia. Babies are diagnosed with reflux all the time. They're spitting up all the time. The parents don't know what to do. They go to the doctor. The doctor gives them the reflux medicine. Some babies, this medicine works like a charm. And, now they're not fussy. They're gaining weight appropriately. They're not spitting up all the time. Awesome. Other babies, we start the medication, and no matter what we do, it doesn't change. We're still not gaining weight. We're still spitting up all the time. We're still super crouchy and fussy. Then the issue might be something called aerophagia. Aerophagia is simply excessive air intake with a bottle. So if you have a baby and their mouth is sealed correctly around the bottle, you're not going to have any milk coming out or any air going in. When that seal is loose, you have all sorts of room for air to come in because every time they're sucking the bottle to get the milk, they're getting more air as well. All that air is upsetting their stomach. And that's something that reflux medications don't help. There's a structural or positioning issue going on, and that's when we go back to checking for tethered oral tissues or changing bottle nipple shape like that. Um, I may have this slide later, and I really can't remember, but I've found that most babies do better with a narrow nipple than a wide base nipple. On the advertisement, they say the wide base are more like the breast, so people who are doing combo feeding, it transitions better. I haven't seen that correlation in practice. Now, every baby is different, but typically with those smaller, skinnier nipples, they can get a much better seal. We're also looking for what's called a lip flange. So the inner pink part of the lip should be turned up, and we should be able to see that pink part around the nipple. That's letting us know that we really do have that good seal. No milk leaking out, and you sometimes can see the tongue protruding just a little bit out of the mouth, cupping the nipple, but that's not necessarily always the case. It kind of just depends on the baby and if they're breastfeeding or bottle feeding, as well as the type of bottle. So yeah, let's go to the next slide. And if y'all have any questions, just ask while we're in here. Oh, look, here it is. So what is in my opinion, the best bottle or pacifier shape? This is something that I get asked all the time. So things that I like to look for, and I have a Dr. Brown's bottle because that's my personal favorite, but there's lots out there. So on the Dr. Brown's, where's the camera? So you see the nipple, it's cylindrical and it's long. So when our babies' mouths are designed for breastfeeding because that's what evolutionarily we were designed to do. When breastfeeding, that nipple becomes cylindrical and elongates into the baby's mouth. So it reaches the junction between the soft and hard palate, and the baby expresses the milk. A lot of bottles, and I wish I had one, but I don't, but you can kind of look at the sippy cup. So this one, it's thick. It kind of has a knob at the end. Babies can do, so you can kind of look at the Tommy Tippy bottle, the the third one. Uh, those kind of have a little bit of that bulb. It's the man bottles that really have it. And those are tongue tie babies' favorites because babies who have tongue ties typically can't produce enough suction with their tongue because their tongue can't raise that they can't suck that nipple in to pull the milk. So those bottles promote chomping, which is how the baby expresses milk. Number one rule of feeding with babies is feed the baby. So if that's how the baby has to eat for now, feed it. We'll deal with it later. But ideally, we want to look for a bottle that has a long, narrow, cylindrical nipple. Let's see. Same with pacifiers. I like the Avent pacifiers. Though recently I've seen like some Dr. Brown's pacifiers, and Itsy Ritzy, I think, is another one that some moms have shown me recently that I've really liked. So at the bottom of the slide, you see the Dr. Brown's, the Avent, the Tommy Tippy, and I think that's the Komotomo. A lot of parents have been coming to me with these lately. Dr. Brown's is my favorite, but Avent, for the few babies I have that do work better on a wider base bottle, the Avents work really well. The Tommy Tippies, they have a good shape of the nipple, but it's not very long. So some of our babies struggle with that more. Komotomo is another wide base bottle. So if your baby needs that, that's a good option too. What's the next slide? Feeding therapist enemy, the MAM bottle. Like I said, some babies need it to gain weight. If that's the case, go for it. Baby needs to be fed, but it doesn't. It promotes the chomping oral mechanism, which impacts things later down the road. We want the sucking pulling. So if you look on the slide, you can see on the left, yeah, left-hand side, you'll see the MAM bottle nipples, how they have the bulb at the end. They're not cylindrical. They're like skinny and then fat. And then on the other side is the Dr. Brown's that are cylindrical. So that kind of just gives you a clue of how the baby's mouth is working, if the tongue's moving or if they're just chomping. Okay, so that's just a quick rundown of babies. Before we move into what I call my older infants, which are my solid feeders, does anyone have any questions about the babies? If not, we can ask it at the end. Okay, I don't really
I
know.
see no questions at the moment.
Okay, perfect. Okay, so older infants. Oh, where did we go? We're back on medical defects. We'll just have to click through a few. One more. Okay, so in older infants, these are my solid feeders. One thing I noticed a couple different areas they struggle with: difficulty transitioning to solids, and that can either be due to difficulties with texture or chewing, are the two most common. Difficulty getting away from the bottle to a cup. They have trouble with oral motor coordination, or the bottle is a comfort item, and difficulty with self feeding, whether it's finger feeding or utensil use. Positioning is super important in feeding. So that's another thing that a lot of times the parent and I'll problem solve how to optimize that position so the baby can eat properly. Next. Okay, so positioning. My kind of rule of thumb is it's not so much an age of when to introduce solids, it's when the baby has good head control in sitting. We don't want the chin tucked forward, we don't want the neck extended. We want the baby to be able to sit upright and control their head. Eating is a fine motor skill, and so if our gross motor skills aren't developed, we can't optimally use our fine motor skills. So for a baby that is old enough for solids but doesn't have the gross motor skills to sit like that, we can use the high chairs to help us with that. You ideally, if you can find a high chair that has the 5-point harness, so that's the chest straps and the lap straps. This is just an example I found on the internet. That is my favorite. The removable chest straps are even better because when baby gets a little bit older, they can sit on their own. We just take those off. But that takes the baby's focus away from making sure they're sitting upright and not wobbling all over the place to being able to truly focus on the skills being worked on in the mouth. If you can find one with a tray like just below the chest so they're not having to lift up with their arms, and if you can get their feet supported, that's even better, because when your feet are flat on the floor, it gives your body more cues of where it is in space and they can feel more comfortable. Next slide. So difficulty transitioning to solids for texture issues. These are kids that you put food in their mouth and they immediately gag. Sometimes they throw up, sometimes they just gag and they freak out. Parents typically think the baby's choking. Usually the baby's not, but babies can be really dramatic with this sometimes. I found a lot of times in this case they have sensory and texture issues elsewhere. So I use a little cradle cap brush and we'll do brushing along the hands, things like that. If you think about it, think of foods that make you think like gross. So for me, that's avocados. I don't want to touch an avocado because it's just gross to me. So if I'm not going to touch it, there's no way I'm going to put it in my mouth. Same thing with babies. So a lot of times we have to start with just touching foods, getting used to food being on our skin, different textures. It doesn't even have to be food. You can do dirt, you can do sand, you can do grass, anything you can think of, and work on that. Once that's kind of calmed down a little bit, ideally we do it at the same time as feeding, but sometimes it's so bad we got to do that first. Then we can start in the mouth. I found that there are a few babies who know purees are a no-go. We just want real food, but they're kind of the exception to the rule. Most babies will tolerate a puree, and when they start having more issues is when we start getting the chunks in it. So a thing I like to do is take something that kind of melts in their mouth. So Cheerios, Puffs, little crunchy Cheeto things that the babies have in the baby aisle. I take that and I crush it up and add just a few crumbs at a time to their puree, and then feed it to them. They slowly get used to that, and I start making the pieces a little bit bigger. After something that dissolves, Cheerios are my favorite just because they're cheap and easy, and they last a long time. So after we've got, hey, we've got little chunks of Cheerios, like half a Cheerio, we're eating that fine, we're not gagging. Then I like to progress to what I call my soft mashables. So those are things like carrots that are steamed super, super well. Apples steamed super, super well. Spaghetti, even if you cut it up fine. Things that are still soft and they mash really well with little effort, but they don't dissolve like a Cheerio would. So that's my next phase is once they can get that soft mashable mixed with the puree and they've got that good, we're ready to roll. Most babies progress really fast from that point. So then I'll take whatever we were using in the puree as a mash bowl and take it out and just feed that to them plain. So little cubes of carrots that are sized appropriately for the age and cut up and really soft. And then I do dry foods. So dry foods are harder to manage in your mouth than wet foods. Wet foods stay together, dry foods fall apart. Um, a lot of kids have issues forming a bolus, which is the ball of food in your mouth that you swallow. So the wet helps with that. So I'll start with dry foods by adding a little bit of that wet to it and then slowly take that away. Kids that are really resistant or just to introduce new foods while we're working on this, I am a big fan of these little feeder bags. Most babies will chew on this kind of stuff because it's safe. It keeps all the chunks inside and they just get the flavor. The silicone one, even more so. It's a great way to introduce new flavors without having to worry about overwhelming them with the gagging. Another thing for feeding with infants is I like to use narrow spoons with shallow bowls. So this red one is my favorite. It's narrow, so I can put it in a baby's mouth and I can easily dump food into the cheek pockets to help them chew it if it's easier. And it's narrow, so they can scrape it off easily. So if you notice, I mean, there's 1,000 different baby spoons, but this white one, which is a popular baby spoon, is like significantly wider. It's much harder to place food in the right locations in a baby's mouth with a wider spoon. I place food on the side of the mouth because a lot of times little ones with feeding issues will have a hypersensitive gag. So anything that touches the middle of the tongue is going to trigger that gag reflex automatically. By kind of dumping the food into either cheek pocket, it lets the baby know, hey, this is food, it's okay, before that gag reflex is triggered. And then infants or children that have tongue ties may not be able to move that food from side to side as easily. So that kind of takes some of the work for them. My other and my biggest suggestion to all families is eat as a family. Um, let them see what you're eating because they will copy you and mimic you in most of the cases. And then if what you're eating is safe and it's not an allergy or like, you don't get babies under one honey or things like that, give them little bits. Cut it up into an amount that's safe. You don't want it to be a choking hazard. You can do long, thin strips or you can do itty bitty pieces and let them play with it. Just put a little bit on their plate. Even if they throw it on the floor, hey, they're touching it, so they're getting used to that texture. Next slide. Okay, chewing. That's another place that I see issues because chewing is a whole new skill. A baby's never chewed before they are introduced to solid foods. So we start out chewing vertically like this. We don't have teeth. So think about chewing like this. It's going to mash like Cheerios. It's going to mash steamed carrots, but this is not effective at all for meat. Basically anything beyond a chicken nugget, which is mashed meat pre-chewed for you, it's not effective. Same thing with hard foods like raw carrots or apples or things like that. So then babies realize, okay, that's not going to work. So they start diagonally chewing. So that's kind of a sliding motion. So you're chew and grind. Eventually it goes to rotary chewing, which is like circles. That is the most advanced form of chewing. But to get that, it also takes coordination of your tongue. Some good exercises to help with tongue movements to coordinate that. I like to use dum dums, and I have usually the kids are a little bit older when I'm working on this because in an infant, it's not usually caught right away that, hey, chewing's an issue. But with my kids, toddlers, and older kids, I use dum dums and I have them stick out their tongue and lick with it in various positions. Then we progress to fruit snacks or mini M&Ms. We'll put it in one side of the mouth, and I'll demonstrate them go rolling it to the other side and then chewing it. And they understand that concept a lot younger than I thought they would. I have 2-year-olds that can copy me doing that motion and just practice. Um, and that helps with chewing. It doesn't sound like it would, but it really does. Baby led weaning is, I never did baby led weaning with my own kids. I'm not super like read in that, but I know that they promote long, thin strips and chewing on those from a young age. And those long, thin strips are great. I recommend that a lot of times. Like if you're eating a piece of steak, cut a long strip so that baby can hold one in and chew on it with the other. Um, Kind of uh, like these kind of teether chewy toys. They hold one in and they can get it all the way back in their mouth. Kids that have issues with tongue movements and chewing, you'll see that immature chewing patterns like this, or sometimes diagonal. You also see them use their hands to move the food around in their mouth. That's a compensation for something their tongue should be doing. So that's when we throw in some of those tongue exercises. We check, make sure we didn't miss a tongue tie or something like that earlier on in life, and we work on teaching them these skills. For little babies, the best way to teach chewing is chew on everything. They're already going to do it anyway, so give them as many shapes, sizes, textures as you can that are safe to chew on. Next slide. Okay, cups. Difficulty transitioning away from the bottle. Ideally, I like the bottle to be gone by 12 months. I'm a mom. I know that doesn't always happen. I've introduced. They say you can introduce straws as young as 6 months. I haven't had much success before 10 months, but some babies get it. Usually, when I have difficulty transitioning from a bottle, it's because it's a comfort item and they use it to fall asleep. Sucking is a very calming mechanism for babies. Basically, the biggest soothing methods for babies are pressure on the palate and sucking. That's why we offer pacifiers, because it gets both those. So when it's a comfort item issue, I try and have families decrease the use to, before bed or nap time at first, and then we'll slowly take it away. The reason that we want to transition away from bottles is it impacts speech development and oral facial development, teeth, and all that kind of stuff. Dentists know more about that, but it can cause some issues. Sometimes, if this usually doesn't work, but I always have parents try, find another comfort item to replace it with. A stuffed animal, whatever works. Usually doesn't work, but it's worth a try. Some people say to cut the bottle nipple. I've used that in certain cases, but it's not my favorite. It's just an option. And in the end, we're going to pick our battles. If we have a 14-month-old that still takes a bottle before bed and everything else is fine, they can drink from a straw during the day, their eating's fine, they're starting to say words, I'm not going to fight that battle right then. If they need one bottle a day to fall asleep and that keeps everyone sane, so be it. We'll deal with it. They'll get off the bottle eventually, but 2 years old is my absolute hard max. By 2 years old, unless there is another medical condition going on, if we have autism, if we have sensory disorder, or some sort of medical based condition, that's another story. This is just for, your typically developing children, preferably 1 year old, but 2 year old for sure. The other issue they sometimes have with transitioning to cups is difficulty with coordinating the movement that they need for cups. So straws are the best. They're the best for oral motor development and speech development. So I have this cup. It's called a honey bear cup. It teaches babies how to drink from straws. So I can put the straw in their mouth and then squeeze it to release the liquid. We start with mouth open and I just squeeze. Then we progress to, okay, whenever they close their mouth, I squeeze. Then I'll kind of prime it and get the liquid to about right there, and then they'll suck and pull it all the way to straw drinking. I've heard that Walmart has cups like these for pretty cheap, worth a try. These actual honey bear cups can be kind of expensive, but they're one of my favorite tools. If you don't have one, you know how everyone used to go to a restaurant, you put your straw in the Coke and you do that, and then bird feeding. do the same method with that. As far as sippy cups, I try to avoid the soft nipples because it's too bottle-like. And honestly, true sippy cups, they're a convenience thing, but they're not the best for development. But you know what? Sometimes you need a sippy cup that doesn't spill. So as long as it's not the only thing they can use, no worries. They also have like these cute little cups and things, child side stuff to work on that open drinking. It's a good skill for them to have. They can get it very, very young. Just start with it outside. Okay, next slide. Okay, self feeding is the other issue. So finger feeding, usually it's because they're trying to grab everything like this and they can't pick up that food. Um, so if that's the case, you can kind of help them pull those fingers down and just let them use these. Put it inside a small cup so the whole hand can't fit in. They just have to use the fingers. Or there may be texture sensitivities like we talked about earlier. So use the brushing we talked about. Or one of my favorite things to do is put stuff in Ziploc bags. Have them play with it in the Ziploc bag first and then on their hands. Utensil use. I always prefer child size utensil. We talked about the spoon earlier, the shallow bowl and the narrow spoon. But child size utensils are much more appropriate. I know they're expensive, but just buy them. Start giving them to them at a young age, 12 months, even younger sometimes, and just let them play with it. It's going to be a mess. Expect a mess, whatever. Sometimes we have kids that will not use a spoon, don't want to use a spoon, whatever. So then I'll take the spoon and a toy. So we have bears that are different colors, and we use the spoon and scoop the bear and put it in the cup that matches its color. Playing with a spoon in a toy is a great way to practice the skill without the fear of feeding. Next slide. Okay, so feeding difficulties in toddlers and young children. These are my kids that, okay, we transition to solids, we're eating solids, but we will only eat chicken nuggets, french fries, and Cheetos. So everyone's seen these picky eater tests. It's just a fun thing to do online, and I will tell you, I score like the highest every time. Like there's like 36 things on that list I won't eat. So yeah. Next slide. Okay, so first we have to figure out what is a picky eater versus a problem feeder. So a picky eater typically eats more than 30 foods. But they won't eat everything, but they have a good variety. A problem feeder, which is someone that we need to address with therapy or intervention, is going to have less than 20. Food jag is another thing. So like your picky eater, they want only chicken nuggets for 6 weeks, and then they won't eat chicken nuggets for a week, and then they'll eat them again. A problem feeder, they'll eat chicken nuggets for 6 weeks, and they will never touch that food again. So their list of 5 foods just went to 4, and nothing has replaced it. A picky eater will tolerate you putting a new food on their plate, maybe try it. Problem feeder will have a meltdown, throw it across the room. A picky eater typically has at least one food from each food group, whereas a problem feeder typically says, I won't have anything from this group of vegetables or this group of fruits. And problem feeders often have times tolerating other people's food they don't like being placed on their plate. So what causes problem feeding? You can have structural issues, like my son had the tonsils that were touching, and he couldn't swallow. You can have tongue ties, sensory difficulties, tolerating textures, anxiety, autism has a lot of feeding, but ultimately we don't know. I just like this little meme because, you never know what you're going to get in a blueberry, but a wheat thin is going to be the same every time. So some things to try. My biggest thing is a no stress environment. It never fails. If you push too hard with feeding, you will take 10 steps back. It never, ever fails me. So do it and play. No stress. Celebrate the little wins and brush off the failures. Eating together as a family, once again, that's super, super important. And I always say, whatever you're eating, make your child the food that they're going to eat because they need to eat. But make sure you put some of yours on their plate too. I wouldn't put it touching, but make sure it's there, and it has to stay there. And then when it's there, you encourage them to interact with it somehow. Touch it with their finger, smell it, lick it, kiss it. Even if it's just, hey, it's time to clear our plate, so let's use our hand to scrape the food off the plate. At least we touched it. And over time, that leads to big gains. Um, Playing with our food. And I do a feeding group where I work for like 4 to 7 year old kids, and we make mustaches. We make elephant trunks. We play flutes with carrots. I mean, anything you can think of. Kids think it's funny from a very young age. Celebrate the little things. If they touched it when they didn't touch it before, that is a huge win. Feeding is not big strides for problem feeders. It is always inchworms. I mean, every inch you celebrate, and miles will come down the road. Another good thing is, so I talked about my feeding group, positive peer pressure. Encourage your kids to get the school lunch in addition to, well, okay, most of these are toddlers, but sometimes children, their school lunch or the daycare lunch in addition to their lunch. So at least they have access to it if they decide to copy their peers. Bring your kid to the grocery store and let them pick out something. Go to the fruit and veggie section and say, what do you want to pick out? And then show them how you can cook with it. If it's an apple, cut up the apple. Talk about, it's red on the outside, white on the inside. It's soft, it's hard, it's wet, it's dry, it's cold. Anything you can do to get them to use and explore. Even if your child can't talk, you talk about it for them. Demonstrate, I'm touching the white part, I'm touching the red part. Encourage them to do it as well. Um, the other big thing I find is a lot of times kids are snacking so much they're not really hungry at meal times. So try and make sure that you are limiting that snacking so they're more hungry for meals. And patience. That's the biggest thing with any age with feeding issues is patience, patience, patience. Um, yeah. Next slide. So that's kind of all I had prepared. I'd be happy to answer any questions if anyone has any or wants any more information. But thank you all for listening.
I had a question, Jenny.
Yeah.
What if a child just flat out refuses to eat?
Um, so that can be a lot of other issues. If they flat out refuse, it's usually more of a, we need to go see the doctor. They can't go long periods of time without eating. We need to, biggest thing, make sure they stay hydrated. As long as they're hydrated, then we can have a little bit more time. But I would go to the doctor. If they won't eat for super long periods, then we have an issue. If it's, I like I said, it really depends on the kid. A lot of times I try and offer all of their favorite foods to get them to start eating again, and then we'll resume with where we were.
Yeah, because when you said that you wanted to do this particular webinar, I was kind of excited because my son, he has autism, and
Mm-hmm.
feeding has always been an issue for us. I've always
Mm-hmm.
had issues with trying to get him to eat. And so
Mm-hmm.
when he was younger, I actually got him on Pediasure, and it kind of helped for a while. But
Mm-hmm.
then by age 12, the doctor was like, "Oh, he's at the weight for his age, so I think we're gonna stop the Pediasure." But his eating habits was the same. So like
Mm-hmm.
now he's 15. So from age 12 to 15, I still can't get him to eat.
Mm-hmm.
And I'm having to pay for Pediasure out of pocket
Oh gosh.
because he still does not eat.
So uh, in cases like, especially older children like this, I look at, are they on any medication that are appetite inhibitors? And if so, is that something we can change? If they won't eat preferred food, it's non-preferred, like they're just not hungry, we need to work on the appetite. So if there's a medication that's inhibiting it, that needs to change. If not, I'll have parents talk to their doctor, especially for kids that are lower on that weight register, about possibly adding an appetite stimulant while we're in therapy. Because if kids aren't hungry, I can't get them to eat foods that they wouldn't want to eat anyway. I have to have them hungry to have them want to try. And then, after we make progress, the doctor can back off that appetite stimulant if they think it's necessary. But I've even used rewards like, hey, for every bite you take, you get a minute of iPad. Like whatever their high stimulus reward is. In therapy, a lot of the times I let them pick a board game and you get a bite and then you get to take your turn. Or you get a bite and you get this puzzle piece to finish your puzzle kind of thing. At home, whatever high stimulus reward you have, use it as a bribery.
Yeah. Yeah.
So,
All right. Well, thank you. I appreciate that.
no problem. Okay. Well, I guess that's it. But thank y'all everyone for coming. I appreciate it.
Do anybody else have any other questions for Miss Jenny? Okay. Well, thank you, Miss Jenny, for all the good information. I'm sure that it will be helpful for the families that we serve. I appreciate everyone for taking the time out of their day to be here, and I hope to see you at one of our next webinars. You can find a listing of the webinars that we offer on our website or our Facebook page. Please do the surveys. Wallace has the links listed in the chat. Um, and enjoy your week. And hopefully we'll see y'all soon. Thank y'all so much. I appreciate it. Thank you, Miss Jenny.
You're welcome. Thank y'all for having me.
All right, honey. Enjoy your night.
Yes, ma'am. I don't know how to make this one. How to stop this.